Yeah, like,
Good evening, everyone. Welcome to iFocus Online, Lecture 178 and Retina Session 30. Today we have with us Professor Parijat Chandra sir, and he'll be talking on retinopathy of prematurity, staging, and management. I'm sure there will be an overlap between the previous class and this, and that's pretty good because that will be a good revision for the postgraduates. I request Dr. Ritesh Narula sir to please introduce Parijat sir.
Thank you, Rolika. Very good evening to all of you. It's my great honor to introduce Professor Parijat Chandra from RP Center AIIMS, a person whose name is kind of synonymous with the retinopathy of prematurity, a person who is known for his skills in management of retinopathy of prematurity, the surgical management especially. He is a member of the National ROP Task Force and engaged in with more than 150 plus index publications and lectures in national and international conference. His predominant areas of interest are pediatric vitreoretinal diseases, and we are really looking forward to learning a lot from him today. Over to you, Dr. Parijat.
Thank you, Dr. Ritesh. I'll just share my screen. Is it visible?
Yes, it is.
So, at the outset, I would like to thank the iFocus team. I would like to thank Dr. Lalit Verma, Dr. Santosh Hanover for inviting me for this lecture, and I am very grateful to them. And I hope we can all learn something more about ROP staging and management. Thank you once again for this opportunity, sir. Let's get started. Okay. So ROP staging and management is what I'm going to talk about today. So the ICROP 3 was released last year and basically updated the classification of ROP, which is very important to learn about ROP as well as for inter-expert communication. So basically divides ROP into zone, stage, and plus disease, and this is the third iteration of the same. So let's first have a look at the zones of ROP. So there are basically three zones. The first zone is the innermost zone, which is basically the disc macula, and twice the distance if you take it, that becomes zone 1. Obviously, because it is the smallest zone and because there's a large amount of ischemic retina there, therefore this gets the most severe disease. This next outer zone is zone 2, which basically is a zone which encompasses and surrounds the zone 1, and this is zone where most commonly the disease occurs, and this is where you will find that nasally it goes to the ora serrata, and temporal, if you see, the zone which is left out is the zone 3. So these are three zones of ROP which are there. The new classification ICROP 3 introduced another zone which is known as zone 2 posterior. So this is another zone because why was it introduced? It was basically introduced because the disease in zone 2 posterior behaved more like zone 1. So there was a need to not only divide zone 2, which was previously divided by many people as zone 1 anterior, zone 2 posterior, something like that, but they devised a more standardized classification for communication between experts as zone 2 posterior. So basically the posterior zone 2 extends into zone 2 for 2 disc diameters. So if you have a case of posterior zone 2, you have to understand that it might behave with some characteristics of zone 1 disease, and therefore it's important to keep in mind. They introduced a new terminology known as notch. So what is the notch? Notch is basically, you see the retina is dipping inside the zone 1. So basically you will label it something like zone 2 and zone 1 secondary to notch. So basically it means that although the disease primarily is in zone 2, in zone 1 it's dipping in some particular area in 1-2 clock hours, which basically means that it might have some characteristics of zone 1 as well. So you need to keep in mind that it might have some proportion of aggressive component to it. While we are talking of this, let's talk about some stages. So what is incomplete vascularization? So earlier we used to call it immature retina. What the new classification says is that you need to call it as incomplete vascularization and not immature retina or no ROP. Incomplete vascularization means that the retina is normally growing from, as you see, the disc towards the periphery, right? So now if it's an incomplete vascularization, it means that you are examining the child young enough and the vascularization has not proceeded towards the ora serrata as yet. But there is no ROP. As you see, there is no ridge, there is no demarcation line, so there is no ROP. So you'll be surprised to know how many people confuse incomplete vascularization with some stage of ROP or AP-ROP. So that's not necessarily the same. Let's see some of the stages. So stage 1 is demarcation line. You can see that the blue arrow on the left photo indicates a junction of the vascular and avascular retina. A fine faint line is seen. This is stage 1. Stage 2, you see a demarcation ridge. A demarcation ridge basically means that the line has gained height and width and is now more well defined. Stage 3, if you see, stage 3 is basically a case of extraretinal neovascular proliferation or flat neovascularization, right? So what this basically means is that you see that the line which was there, or the ridge that was there, now has started growing neovascularization, and that is growing into the vitreous. Stage 4 basically means partial retinal detachment. 4A is when the fovea is attached, 4B is when the fovea is detached. And total retinal detachment basically signifies that you are into stage 5. Now the new classification also divided stage 5 into 3 parts: stage 5A, 5B and 5C. 5A basically means if the optic disc is visible, 5B means that the optic disc is not visible, and 5C means that anterior segment changes are there. So basically 5A will signify more of an open funnel configuration, 5B will basically signify possibly a closed funnel configuration or a retinal membrane is there, and 5C means that the changes have involved the anterior segment in the form of posterior synechiae or shallow anterior chamber or iridocorneal synechiae and something like that. The third important component of classification of ROP is plus disease. So if you see on the left side, the first classification divides this as the standard plus photograph. Basically what it meant was the dilation and tortuosity of vessels which you want to see. Now this is the plus photo in the latest classification, the standard reference photo. So basically what you are observing is that the retinal vessels at the posterior pole are dilated and tortuous. Now you need to examine this in zone 1. Don't examine this in zone 2 or zone 3 and you find posterior and you find that the vessels are dilated tortuous and you call this as plus disease. Plus disease should be only called at the posterior vessels and not on anterior vessels. Now there is another component known as pre-plus disease. So pre-plus disease basically means that you can see the dilation and tortuosity, but it is insufficient for plus, but is definitely more than normal. So now basically they signify this as a continuum of disease which goes from the normal dilation tortuosity to pre-plus to plus. So it's a continuum of disease. As the disease progresses, this thing will continue to increase. Let's look at the another component, which is aggressive ROP. Now earlier it used to be called aggressive posterior ROP by the previous classification, and much before that people used to use it as rush disease, fulminant ROP, type 1 ROP. A lot of these terminology were used which used to confuse people. The basic idea of aggressive ROP was that it signifies a disease which progresses very fast, is aggressive in nature, and therefore you need to watch out for it because it can lead to very quickly to retinal detachment. So why did they decide to change the terminology from AP-ROP to aggressive ROP? It's basically because they found that it's not necessarily posterior zones, it can be a little anterior as well, and it's occurring in larger babies as well. Therefore aggressive ROP would be a more suitable terminology than aggressive posterior ROP. So what is it exactly? Let's see a few slides about these. So basically occurs in the posterior zones. It's got a deceptive featureless junction. So if you see the left photograph, you find you cannot see exactly the ridge, the line which you see was there. It's no longer there. So it's a deceptive featureless junction. So if you keep on waiting for the line or ridge to come, basically it's not there. Instead what you see is a kind of flat neovascularization which can be there, which is might not be apparently visible to the naked eye. Then you can notice there is severe plus disease in the form of dilation and tortuosity of vessels, and there can be rapid progression without going through the classical stages 1, 2, 3. And obviously the more important feature which you can see is that there are arteriovenous shunting and direct vascular loops, which you can see in the photo below, that you see this loop is there marked by the green arrow. So this is just an avascular retina. If you match the color on top and if you match the color inside the loop, they're almost same. So what you have here is just a vascular loop going there, which is around in the avascular retina only, and you need to treat this if you want to cure the disease. So now let's come to how to treat ROP. So ROP, basically there are 3 modes of treatment which are there: laser, anti-VEGF drugs and surgery. These are three modalities primarily which we need to treat ROP. So we know that laser has been there for a very long time. Cryotherapy was there in much earlier stages, which is no longer used. Now we use laser for ROP. It's been used for a very long time. The ET-ROP trial, you can see, came 2 decades ago. It stood the test of time very well. It advised treatment at the pre-threshold stage, and this is mostly what I'm trying to show in this chart, is that you can see that zone 1, mostly all cases you need to treat. Zone 2, stage 2 to 3 with plus, you will need to treat. So these are all, they classified this into type 1 ROP, and type 1 ROP needs to be treated within 48 to 72 hours by laser treatment. And this works very well, and I think most of us are using this for laser treatment. It stood the test of time for 2 decades, and it leads to very good regression outcomes. The idea basically is to treat the avascular retina, which is anterior to the ridge, because that is what is causing the ischemic stimulus, and that is what you need to treat with laser, which will cause scarring and reduce that oxygen demand and reduce the VEGF, and that will eventually lead to regression of the ridge. So let's see how this case, you see on the left photo, you can see that it's a stage 3, stage 2 anterior patch which is there, and if you laser it, on the right photo you see the laser marks are there, and this whole ridge and all those new vessel patches have all gone away. So I recommend you read this article by this group of experts below, which will give very good technical insights into how to laser these cases by Dr. Jalali et al, and you will get a lot of useful insights from it. Some of us like to use posterior barrage laser to treat ROP in some of the cases which are rapidly advancing. So we used to use this mostly earlier when anti-VEGF and surgical options were not available. We used to do this in the hope of anchoring the retina, in some hope that it does not go and detach the posterior retina. This is what it looked like if you see the right photograph. You can see these laser marks. The ROP has regressed, and these laser marks which you see are basically the posterior barrage laser marks which are there behind the ridge. So this is not recommended and is basically used in selected cases now. So for example, if you get this case now, which you see on the left side, probably injection with surgery with laser would be a better option in this rather than waiting for a posterior barrage laser. However, it's not to say posterior barrage laser is used in selected cases in anterior zones where they don't come very near to the macula. So doing laser the correct way is very important, so that you can do bilateral laser in the same sitting, and you have to laser the avascular retina. A lot of people like to do PRP. So PRP is recommended for diabetic retinopathy for PDR. It's not recommended for ROP. We should not be lasering the vascular retina, which is anyway small in size. You don't want to destroy a good retina. Don't hit the ridge. If you hit the ridge, you will end up with retinal hemorrhages. It might incite further proliferation and incite contraction of the ridge. So don't hit the ridge. Keep the cornea lubricated. This is especially for newcomers who start doing ROP laser. You have to keep the cornea lubricated so that you can do it easily. Indent gently, immobilize the baby well. It's very important to understand that laser is a painful procedure, and therefore we give fentanyl for laser procedure. This is just a photograph of the pediatric high dependency unit which we have at AIIMS, where a dedicated pediatrician takes care of these babies during the laser procedure. So if I just put in one word, you need trained personnel to do laser. Laser is a painful procedure. It requires specialized skills to laser in a preterm baby, and it's a painful procedure. You don't want someone who's going to spend 3 hours to laser a child who's going to desaturate and develop further complications due to a prolonged procedure due to pain. So a lot of work is going on for the pain. This no pain trial was recently done at a place. So even despite giving fentanyl, ketamine and all, still if you check the pain parameters, still a lot of pain is happening in these babies in topical procedures. So let's look at some of the aspects of laser in AP-ROP or AROP. So this is a challenging situation, especially because AROP poses unique challenges. You cannot see where the ridge is. So it confuses even experts who sometimes get challenged. Should the disease be lasered? Where is the ridge? How much should I laser? So a lot of this posterior zone 1 ROP is also coming in, which basically means that the macula is not vascularized, although it's not in the IC-ROP classification, but still it's a reality where if you see the macula is also not vascularized, and it's even half of zone 1, sometimes known as half zone ROP, where do you go and laser? So this is just to show you, we did angiography in this case, so just to show you, if you see the blue area or the blue arrows are where, beginner will start to laser, because that's where he thinks that, that is junction between the vascular and avascular retina. Whereas if you see the red arrows is actually where the junction is, and if you see what is there in between is just some malformed vessels, some AV shunts, some vascular loops, and you see the black areas in between, they're basically, it's all non-perfusion areas. So if you do not laser these areas, then this disease is not going to go away, and you can get all kinds of surprises. So it's very important that we laser the avascular retina completely if you want the disease to go away. Just to show you another case here, so you see here that this is again a case of APROP. You can see dilated posterior vessels. Now again nasally you see it's a half zone RP. You don't know where exactly should you laser. Just to show you with angiography. So you don't need angiography in all these cases. This is just to show you that there is extensive flat neovascularization in this case, which is not exactly visible on a red cam photograph, not exactly visible so clearly to the naked eye, and it takes experience to visualize this flat neovascularization, but the angiogram clearly shows that it's there, and you need to urgently treat these eyes. Just a few words about how not to laser. A lot of cases which we get, come like this. This is something similar to the posterior barrage laser I showed you. This is not to be done, You need to laser the avascular retina, which is anterior to this line, which I have just drawn on this photograph. So that is the avascular retina where you need to laser if you want this disease to go away. If you laser posterior to it, you can land up with, further progression of the disease. So that is not to be done. This is another case which I like to show because, it's a very sad situation. This was a child of a doctor. The green arrow actually you see is where the actual ridge is. You can see it's slightly lifted there, and if someone had to do laser, they basically had to do anterior to this ridge. And as I told you earlier, people like to do PRPs for some some reason, and you can see the macula is also lasered in this case, marked by the red arrow. And so this is something which is not to be done. The laser marks are there for life, and this can all lead to potential medical legal cases. So we need to laser with care, so that we know we don't end up in this kind of problem, and we don't create iatrogenic decrease in vision. Whereas in this case, if you see it's a zone 2, very easily the disease could have regressed just by laser in the anterior vascular segment alone. So laser in APROP or AROP now as it is called, we used to do 5-7 years back a lot, and because that was the primary mode of treatment which was available to us. And this is what it looked like, and had you shown me this photo 5 years back, I would have been very happy that APROP has gone away, and very nice laser someone has done, and the disease has regressed, and we are very happy about it that we were able to control that. I did not go into stage 4 or 5. But you see, there are a lot of problems in the current scenario in 2022. If you look back at this photograph, there's limited visual field for one, because you've lasered a large part of the retina. There's poor macular perfusion. You really don't know the macula is properly vascularized in this or not, and obviously there's a risk of high myopia if you go on lasering in these eyes. So what is the way out? Are other treatments available? So anti-VEGF changed a lot of this management of AROP because of the sheer advantages which it has. So it all started in 2011 with the BEAT ROP trial, which was a study which totally changed the way and brought anti-VEGF into the forefront of ROP management. Although the trial was small to assess safety, it showed significant treatment benefit for zone 1 with significant revascularization of the retina. Recently, however, the Rainbow trial results were also released, which again showed that there was this significant benefits of ranibizumab in zone 1 as well as zone 2 ROP, and it was a multicentric study across the world, and it showed excellent results in injection over laser. Based on this report, the European Union approved ranibizumab as a pharmacological treatment option for ROP, which gave a lot of support to the use of anti-VEGF in ROP, and provided a lot of support for regulatory authorities to inject and support ophthalmologists for the cause. Recently, again, the 2-year outcomes of Rainbow were also released, which again confirmed the outcomes of the original Rainbow trial, and retained the high vision benefits which were there. So there's no doubt about it that anti-VEGF has emerged as the first-line treatment for zone 1 ROP, and it has led to rapid ROP progression. If you inject this in zone 1, there is a huge advantage of retinal revascularization because the retina continues to go into the periphery. There is a better visual field, better foveal structure, and there are lesser refractive changes which happen when you compare this to laser. In addition, it's a much faster procedure compared if you want to, laser is going to take hours, and obviously it has much less pain, and the baby is more stable during the procedure. And so definitely benefits are there in anti-VEGF in zone 1 ROP. Now let's see some particular scenarios where we find that it turns out to be very useful. So this is a typical scenario which you found in zone 1 cases, where you open the eye, you see extensive neovascularization of the iris is there, the pupil does not dilate, the extensive tunica vasculosa lentis. And if you see, it's very difficult to do any kind of procedure in this eye. If you want to do surgery or you want to do laser, it's very difficult to do a good laser treatment in this eye. So earlier, it's surprising how we actually used to struggle for laser in such eyes. But now if you inject anti-VEGF in this eye, this is what you get in 3 days. So it works like magic. All the neovascularization just disappears magically, and you can very easily go ahead and do surgery or laser or whatever you want to do to further augment and treat these eyes. So this is one of the major advantages of anti-VEGF, which we did not have with other treatment options. Another huge advantage is rapid disease regression, which you see. Again, what I'm trying to show you here is a zone 1 AROP, which you can see a small amount of neovascular tissue at the disc. Again, you see it's a zone 1 AROP, actually zone 1 posterior AROP. You can hardly see any retinas there. So what is the use of lasering this whole eye, and you get nothing out of it? So if you inject this eye, let's see what happens. This is what happens in the next 2 weeks. And you see that tissue over the disc has gone away, the hemorrhage is clearing up, the vascularization is going in, and this is what you see at 6 weeks. You can see some amount of vitreous membranes are there, but otherwise you can see the retina has grown very well. The disc you can very clearly see. So this kind of magic is only possible with anti-VEGF alone, and we should consider using anti-VEGF drugs in these cases. But I think the biggest advantage which I see right now of the anti-VEGF drugs is this. So again, I'm showing you a case of zone 1 posterior ROP. You see very small amount of zone is there. And if you go ahead and do laser again this eye, nothing much is going to come out of it because hardly any retina is there. A lot of people try to do, laser in zone 2 and zone 3 in the hope that, this will grow. This is not going to grow. Whereas if you do an anti-VEGF injection in this eye, you will find that dramatically the retina will continue to grow. And I think this is the huge advantage which we have with anti-VEGF drugs, which was again never possible with laser. And it has totally revolutionized the management which we have with anti-VEGF drugs. And there should be, I think, no reason for any hesitation to use them, because we should give a chance for the retina to grow in these eyes. We are further expanding the the usage of anti-VEGF drugs. So this is a case where you can see a lot of traction has started to develop, and you can see a lot of neovascularization is there. So ideally, this is typically a case for laser treatment. But if you do laser only in the eye, there's a chance that this traction might continue to progress. And if it continues to do that, then again you will try barrage laser, or you will try some other thing. And if it continues to progress further, then you might go into surgery. So sometimes we do combine laser with anti-VEGF, and we find that the outcomes can be very good in these eyes. And you see, this is just a photograph of 7 days, and you can see how well the whole thing has disappeared. And so the predictability of treatment is there, and the outcome is more in your control rather than in the control of the ROP process. Why we do it? We should also know when not to inject. Injection, although it works very well, but this photo I'm trying to show you is a case which is already lasered, and you can see it is a a small zone ROP where you can see extensive traction is happening. 4A has developed. Now, if you don't inject in these eyes, so this case was referred to us from somewhere. We posted this case for surgery, but apparently the parents didn't want to give consent for surgery. So they went ahead and someone else injected this eye, and this is what it turned out to be. So this eye just started closing up. So what I'm just trying to convey to you is that anti-VEGF does not work in all situations. Sometimes, surgery is a better option than injection. You can see a progressive 4A is happening here. It's already lasered. So injection cannot fix this. If you inject in a elevating retina, and there's a high chance it will go into crunch phenomena, and it can worsen very fast, and there's nothing you can do about it basically. So it's very important that you don't lose the valuable early surgical advantage which you can get out of doing an early surgery. Injecting safely is very important. So if you want to maintain safety, it's very important. First is the consent. Then you need to monitor in the presence of anesthesia pediatrics person. Bilateral injection we usually do in the same sitting because the disease is usually bilateral, aggressive posterior in both the eyes. Better to do in the same sitting in both the eyes. But obviously you have to treat it at two separate procedures. You have to clean rip again, and all the sterile precautions have to be taken. We try to use two separate drug batches if possible. And we always inject in the operation theatre, although a lot of our colleagues do like to inject in the NICU, but I feel injecting in the operation theatre is always better. It gives you the sterile environment, it allows proper monitoring by a pediatrician or anesthetist, and the OT microscope gives you excellent magnification, so inject in the right plane and in a more controlled environment, which is not possible if you just go in the NICU and start injecting these babies. So although there I understand a lot of limitations and other people might not be able to inject in the OT for whatever logistic constraints, but this is how we like to do it. A lot of challenges are there, a lot of questions arise in the mind of people who want to switch to anti-VEGF, which drug to use. So all the drugs are being used. Earlier people started using bevacizumab. Now people like to use ranibizumab. Ranibizumab is approved, as I told you, in the European Union, and the company also advises for ocular use. So a lot of regulatory bodies are there. A lot of literature is now there about ranibizumab. The Rainbow also use ranibizumab. So we also use ranibizumab. It's provided to us under the JSSK program of the Government of India, and a lot of people are now experimenting with Eylea as well. So all these reports are coming in. All of them work very well, and you can try either of them. It's just a cost factor for most. What dose to use? So universally half dose is being used in most of the studies. If you see, all the good results are also being reported by 1/4 of the dose, by 1/10 of the ultra low dose also people are using, and they are reporting very good results. But this is the problem, is if you keep on reducing the dose, hardly 1 or 2 drops anyway go inside the eye. So if you try to give a very small dose, very difficult to measure for one, very difficult to inject a very small dose, nothing might go inside the eye. So there are those logistic issues which are there if you try to inject a very small dose. So half dose works well. And how many injections? So usually one injection works very well, and then you can do the rescue and fill it up if it does not happen, which I'll come to very quickly. Systemic safety was a concern for a lot of people, and definitely when the drugs came out, it was a concern because anti-VEGF going into the systemic circulation, it had a chance that it could stop the physiological VEGF, and which was necessary for growth of the brain, liver, kidneys, etc. So there were a lot of concerns, and there were definite reports that anti-VEGF is getting absorbed systemically and can cause systemic VEGF suppression. But it's been a decade now since anti-VEGF come. A lot of reports have come. A lot of people have studied the neurodevelopmental anomalies and other safety aspects and VEGF levels, and it's pretty safe in that regard, and people have compared through various studies, and so the safety issues are not significant enough as yet to not inject, and because the benefits clearly outweigh the risks which are involved, and that is there. So again, I just want to show you that there's a Cochrane review which we recently did, and there are really not many randomized controlled trials which are there to really prove a lot of long-term safety and to prove a lot of results, except very few recent studies which have come. I think the biggest concern right now which we have is managing reactivation. Reactivation is the biggest problem which we have with all of these drugs, because the effect of the drugs finishes at around 6 to 8 weeks, maybe a little longer with bevacizumab, maybe a little longer with aflibercept. But in 4 to 8 weeks, 10 weeks, the effect of the drug wears down, and then the disease starts to come back. This can happen in a large number of cases. It's been reported from 20 to 80% if you review the literature. So you need to keep a very close follow-up. You need to keep a watchful eye, and especially with ranibizumab, it comes back in a large number of cases we have observed. So you need to keep a watch, and obviously the disease regression occurs very nicely, but it can come back. So you have a watchful eye for the reactivation, and if it is happening, then you can go ahead and do laser of the vascular retina. So we like to do early laser whenever we see that the plus disease is coming back, we see that the stage 1-2 is coming back. We like to go ahead and laser the remaining retina so that the disease goes away. Sometimes if the patient is lost to follow-up, the reactivation can be very severe. He could have extensive threshold kind of disease, extensive neovascularization. Then possibly you might need to re-inject these eyes, because laser might not work so well in a rapidly reactivating disease. In those cases, you might consider this as well. Peripheral avascular retina is another terminology which came out in the ICROP3, where basically means that although the retina has grown, a significant amount of area might still be left avascular. Now, there's some problems of significant PAR that if the child manages to grow up, and he can develop lattices, holes, laser, thinning of the retina, and lead to other problems related to that, like retinal detachment, etc. But on a shorter scale, it can lead to a delayed reactivation, which we might not able to pick up because the parents can lose follow-up, and then you can get stuck with the child who comes back with the retinal detachment and other severe reactivation. It might be difficult to manage these children. So basically, if a large PAR which still persists at 10 weeks, 12 weeks after injection, you might consider laser of this, especially if you're going to break follow-up, parents do not want to come back, and when as the child gets bigger, it might become difficult to examine the child without GA. So you might consider laser of the PAR. This is another sad thing which is happening again, because many people are injecting in the ICU without magnification, and the child is moving, not properly immobilized. So you don't get this kind of control which is there if you don't use an operating microscope, because one person can hold the head, other person can put a proper speculum, offsite, have the magnification of the microscope. So it works very well, but if you don't do that, a lot of these cases are coming to us with injection related complications like cataracts. A lot of them are coming, and I think we see around 3-4 cases maybe every month which come referred to us with the cataract. And this is another problem, endophthalmitis. So again, an operation theater gives you that sterile environment which you need for injecting these eyes. Otherwise you can end up with endophthalmitis, which mostly leads to very poor prognosis in these eyes, and the eye can be lost. Very difficult to manage an endophthalmitis eye. So let's now talk about ROP surgery. So ROP surgery has its own challenges, and there are very few centers which deal with the ROP surgery. It's a very special case scenario, especially challenging for anesthesia team as well. So unless you have an experienced anesthesia team who's well versed with anesthetizing preterm babies, you can spend like 1 hour and they can just keep on finding the IV, and so it's a huge problem. So you need an experienced anesthesia team, you need an experienced neonatology team which will give backup to this baby after he goes out of surgery, so that you can have a safe outcome out of surgery. So how are the results of stage 4 ROP? You see a high nasal TRD is there in this case, and so this is how it's operated at 4 weeks. So you see the outcomes are very good if you operate in time, and it's almost as good as new if you operate and the disease tends to go away. Just to show you the basic principle. The basic principle obviously is vitreous debulking, remove all that VEGF load. And just to show you that there are 3 types of traction which are there. So this is the vertical traction, which is showed by the white line. So this you have to relieve the vertical traction. Then you need to relieve the centripetal traction which is there, which is the bands from the disc to the TRD. And then circumferential traction you need to relieve the green lines, basically, which are joining the wrist together so that this traction can fall back on either side. Just to show you a small case. So this is 25G vitrectomy which is happening, lens sparing. So you see again I'm trying to remove the traction as I showed in the photograph between the disc and the TRD, so that it falls back. So this is a case of stage 4 AROP. You can see laser marks in the periphery. So you cut all this, going to bleed because all this is going into the vitreous. You can see the circumferential traction is there, that white band. So we're just dithermizing the raised ridge, and there you can see the circumferential traction is also cut now, and see this gone. So the circumferential traction, vertical and centripetal traction all have been cut. Localized PVD is being done, and this is what it's basically all about. Here's another case. This is more of a posterior case where you can see now this is a zone 1 stage 4 ROP. So we're just trying to remove the traction which is there, and you can see fresh laser marks have been given just prior to surgery, and vitrectomy has been done to relieve all this traction and remove the vitreous load. You can see all the yellow vitreous is now gone. You can see the pink glow is coming very nicely, and once you do that, that's how it looks like, and this is what it looks like at 4 weeks. So fortunately we got an outcome like this, but a very likely outcome of this kind of case would have been the funnel would have just closed over itself and you would just have a cauliflower like sitting there. So fortunately we had a good outcome, but this is a very late scenario to refer a case for surgery. Another quick case to show you, this again you see is a case of someone has heavily lasered an AROP case, and there's a dense membrane sitting on the macula, and you can see the blue arrows mark where attraction is joining the membrane to the peripheral TRD. So this is 27 gauge vitrectomy which is being done in this case. So as you can see what is being done, so 27 works very good if you want to just deal with posterior case scenarios, not too much peripheral scenarios. You can see all this membrane is being cut, and you can see a retinal fold is there behind. And once you can remove that membrane, so a very small amount of retina is there, you see, not much is there. And so this helps release the traction from the periphery to the disc which is there. So what I'm trying to emphasize to you is that early intervention is the key here. So don't wait for a scenario like this to happen before you refer. Don't wait for a scenario like this to happen before you refer. These are all late case scenarios. We should not be waiting for a disease to become like this before you refer the case to a higher center, if you are not able to do it yourself. So you should refer much earlier. So this is an early TRD 4A which has started. This is an early case which has started. So this is when you should be referring, when the surgical outcome can be very good for surgery. It will be almost as good as new. You won't even find that the 4A was there after surgery. But if you refer late, even surgery has its limitations. The contraction can continue and the outcomes are poor. So we should not delay referring for surgery and keep on praying that somehow the disease will go away. It's not going to go away. So we need to go in early. Dr. Dokra has popularized this all nasal approach. This works very well if you want to have a case of temporal TRD where you see that they're sitting on the nasal side and trying to release the traction. So this is there, and this is another thing which we found very useful. So you can see what is happening in this case is it's already a lasered zone 1 ROP which has been referred to us. You can see it's in stage 4A. Extensive neovascularization is there. So in such cases, if you do surgery alone, it's not going to work because this is just going to crumple over itself and close over, because there's extensive neovascularization. Surgery cannot take care of this kind of extensive neovascularization. There's a very high chance you'll end up with intraoperative bleed, very high chance you'll end up with postoperative bleed. So it's very important that you combine this with anti-VEGF, and this kind of outcome can be achieved. So this kind of outcome is just not achievable by surgery alone. If you combine this with anti-VEGF, then only this kind of outcome can be obtained. And if we can do it, why not? Why shouldn't we try this kind of outcome by combining both of these together? And it works very well. So we inject at the end of surgery under air, the anti-VEGF goes in, and this is how it can come out to be very nice if we combine both. What happens if you get a case which is bilateral progressive? So most of these cases, when they come to you, they are referred in 4A in both the eyes, and if you keep on waiting to operate one eye and take the other eye in the other session, if you can inject in the same session both the eyes, why can't you do surgery in both the eyes? So we like to do, as we call it, immediate sequential bilateral vitreal surgery. So a lot of people do it. It's not that only we do it. A lot of people like to do it, and it really helps to take care of both the eyes in one go. Especially if you see cataract surgeons like to do it for congenital cataract in the same sitting. So it really works very well. You can take care of the severe progression in the same sitting. It allows timely management both eyes, and especially because the babies are very sick, giving a single exposure really helps, because the most problem happens while inducing and exiting from the GA, and if you can minimize that, it's really helpful. And especially because the babies continue to get sick, so you might operate one eye, the child becomes sick, and then the other eye is lost. So it's always better to go in one go. But it's very important that you counsel the parents and you treat the second eye as a second surgery, which basically means you clean drip again, the team re-washes, you change the fluid, you change the instruments, so that all safety precautions can be taken, and it's just like another surgery. It's not just a part of the same surgery. So this really helps to take care of both the eyes in one go. Stage 5 ROP is a very sad situation. Unfortunately, we get a lot of stage 5 ROP in India and a lot of the developing world as well. The surgical results are poor, but we still like to give a trial of surgery for these eyes, just in the hope of getting some navigational vision. And this is again very sorry state of affair which is there. This was a study published from the Arvind group a few years back, and this is just to show you the knowledge, attitude, and practices of pediatricians. And these are all pediatricians with good practices and certified pediatricians. And you see a large amount of them had a lot of gaps in the knowledge about what is ROP and how to treat ROP, and so a lot of these limitations are there. A lot of studies are there in literature, if you see, where there's a huge gap in knowledge of the pediatricians for this, because of a lot of stage 5 ROP is happening. Fortunately, a lot of societies from the neonatology, the Indian ROP Society, and the NNF forums have pushed a lot of effort to educate a large number of ophthalmologists and pediatricians to get trained in this. With all the efforts of Dr. Dogra, Dr. Azhar, Dr. Jalali, Dr. Vinekar. A lot of these efforts have been done to promote knowledge among the pediatricians and ophthalmologists and many more excellent and leading ophthalmologists in our country. So what is the basic problem which is happening here? The basic problem which is happening here is that there is a lack of screening, and that is what is actually causing this stage 5 to happen to a large extent in our country. Stage 5 happens in 32.4% of the cases which were referred in this series, and 89% of them were never screened for ROP. It's a very sad situation. And if you see that 18% of them were referred from the capital city of India. So we're not talking about small villages where this number could be really very high. This is happening in the capital of India, so the scenario you can understand is very grave. This was a recent study which was published by the Dr. Vinekar et al., where they found and they've summarized a lot of these medical legal cases in an article where you can read more about what are the cases which happened and more details about them. So the COVID pandemic has totally, derailed the stage 5 experience because we are not able to treat these cases. A lot of missed and delayed screening is happening. A lot of emergency surgery is happening because of stage 5 gets less priority because they are poor prognosis size. And so many stage 5 babies are coming that it's absolutely, devastating to see that so many babies are going blind. I particularly like this article by Dr. Hanover, if you see, Navigating the New Normal, which gives insights into how our life has changed in the current scenario. So this is what happens if you look into stage 5 ROP. It's not like a typical RD, which is reg. It's more like a tractional RD. A lot of these attachments are there. And this is typically how Dr. Sen has tried to explain how these attachments lift these cases into stage 5 ROP. It's not just like one band goes and lifts. So there's a different methodology to this and definite process to this, how it lifts. So this is essential for people who want to go in for stage 5 surgery and learn stage 5 surgery, how this is happening and which attachments you need to release if you want to successfully operate these cases. And you get vitreous hemorrhage like a picture in many of these cases. So many people write, you've got vitreous hemorrhage, you've got cataract. So this is not to be confused. A case of preterm coming with leukocoria with a clear lens is mostly you're dealing with a stage 5 ROP. Don't get confused by an ultrasound like this. Mostly it's because of subretinal echos, which you get a picture like this. And you should not be confused with vitreous hemorrhage. With stage 5 to operate, so stage 5A, if the optic disc is visible, I don't think if you can make the outcome better than what it is, then possibly you can go in for surgery. But most of these cases, if I can see something like this, I may just decide to leave them alone because they are anyway this child is seeing. And if you go in for stage 5 surgery, you have to remove the lens. And is this not better with the lens, with an open funnel like this, with an attached or not attached posterior pole? And he might see better without any surgery. In stage 5B and 5C, surgery can be tried depending on how much media clarity is there. And obviously it's a more challenging situation, but you can go ahead and try in these cases. There's a short clip of how I like to do it. So this is 23G MVR going in, and through that 25G instruments go in. This allows for a snug fit, and here lensectomy you can see is being done, and here you can see the so this is an open funnel configuration, and I'm just trying to show you how non-complex this surgery can be in these situations. Not much dissection is needed. I'm just removing the the vitreous membranes in the center, and you can see it's opening up so nicely. There you can see the disc is there, and this last bit of tissue which you can remove. You can find that there's the attached posterior pole behind, and although that's not so healthy, but it is there. And so what you can see is that now this is how it happens, and this is in the end of surgery. You can have a sutureless closure there because it's a small gauge surgery, and this is the outcome at 4 weeks. So what I'm not trying to say is that it has a good outcome. Stage 5 ROP has a universally poor outcome, but we do attempt surgery in the hope that if some kind of navigational vision can be obtained, the posterior can be opened up, at least you can get rid of the retrolental membrane, the posterior synechiae can be released. If you can release the corneo iris synechiae, then again you can at least let light fall on the posterior pole. Although it's detached, it can behave like a chronic old RD. And if the child can get some kind of navigational vision like finger counting close to face, hand movement close to face, their life changes. They can start recognizing the shadow of their parents. They can recognize the shadows of the door, and they can go to the toilet themselves. So that is a life-changing experience for these children, not only the children but also for the family. So we should attempt surgery in selected cases if it can give a benefit to these families. Parent counseling is something which is very important. We tend to overlook it. We just tend to say poor prognosis and just say bye-bye to these families. We sometimes get complications in operating stage 4 surgery, complications during laser injections. The child can have severe morbidity during these procedures because they are complex procedures, time-consuming procedures, and can lead to problems in the stability and systemic safety of these babies. Grief management and psychological support are very important. We should not overlook it because it is a very important component of healthcare, and it helps to not only console these parents, but also is very essential for humanity as a whole to do this. Rehabilitation is a very important thing. If you don't have a rehabilitation facility, it's better to rehabilitate these babies, send them to a facility where rehabilitation is available. But you just not let them go that you have poor prognosis, go home, nothing can be done. Rehabilitation is a very important component. This is just an insight into our community ophthalmology department at AIIMS, so where they are providing these facilities. So if you provide visual aids, orientation, mobility training, activities in daily living, help for special school admissions, blindness certificates, it helps these babies become able citizens of the society. It helps the family. It helps the child develop his own personality and become useful members of the society, and go on to become engineers, doctors, whatever they want to become with whatever vision they have. So what is the best way to avoid all these challenges? Obviously, it is to prevent ROP. So if you can prevent ROP, that is the best way. Yes, it is a disease which can be prevented. It's a disease which starts due to poor and ICU care. Unfortunately, a lot of our cases come from poor and ICUs. So why do we get cases which are so few in AIIMS or PGI or many other centers which are there across India, and why do we get referred with so many cases of stage 4 or 5 AROP across India? Why is it happening? Because good NICU care, like judicious use of blood transfusion, maintaining proper oxygen saturation, and preventing sepsis, anemia, things like that, all these good NICU practices which are there's a long list of them which you can discuss with your pediatrician. They help to prevent ROP. So although we get hundreds and hundreds of lasers and AROP to our center every year, we hardly get any case for laser from the own AIIMS and ICU. Why is it happening? I have never seen a case of aggressive ROP or stage 4 or 5 coming from the AIIMS and ICU, whereas we get so many of these babies coming across the week. We get 5 cases of stage 5 coming every week from elsewhere. Why is it happening? It's happening because of poor NICU care. So if you can improve the NICU care, as a lot of these societies are doing to improve the care of these babies, it is really going to go a long way. As simple a small thing as a blender will really go a long way to stabilize these babies and prevent the occurrence of ROP. And just to conclude, we need to prevent ROP blindness. ROP blindness can be prevented. The best way to do it is to obviously prevent ROP. The next best way to do it is have a dedicated ROP screening programs in every NICU. And if you find that the ROP is increasing, refer in time. Early referral is very important. If you cannot do it in time, if you cannot do laser in time, injection, surgery in time, refer in time at least. And if the child gets timely treatment, ROP blindness can be prevented. It's a disease where there are national and international guidelines for ROP. It's a disease where a large number of centers are available for screening, large number of centers are available for laser, injection and surgery. So if we can do all this, it will go a long way to prevent ROP blindness. Thank you so much.
Thank you, Dr. Parijat. That was very comprehensively done, and I'm very nicely put up those newer guidelines in staging and classification, which is something which generally, as of now, textbooks are not having it in that much of detail. So thanks a lot. Rolika, can we start firing our questions to Dr. Parijat?
Yes, sir. Thanks a lot, Parijat, sir, for the wonderful session. There are a few questions that are there on the Zoom platform and YouTube and Facebook. So I'll be taking one by one. So Dr. Soni has asked that in any vitreous hemorrhage in ROP babies, is vitrectomy practiced and preferred?
Yeah, so that will be dependent upon the extent of vitreous hemorrhage and exactly what is the situation. Are we dealing with a case of ROP or not ROP? If it's a case of ROP and the child is developing vitreous hemorrhage, So you need to look why the child is developing vitreous hemorrhage. Is he having stage 3? Is he having aggressive ROP? So basically, if it's happening out of causes of birth trauma, it's basically happening because of ROP. Then you need to see why it's happening. Does the child need injection? Is the vitreous hemorrhage localized? So if it's localized, then possibly you can wait, or you can investigate why it's happening. If it's happening, it needs treatment. If, however, the vitreous hemorrhage is significant enough to block visualization, then possibly you might need to go in with a vitrectomy early and see why it's happening. If you have a case which is like 36 weeks with vitreous hemorrhage, is it a case of stage 5 already? You might need to do ultrasound and see. So it depends on the extent of vitreous hemorrhage and the disease. Yeah.
That's true, sir. So the next question Sony has is that if there is high risk of myopia in ROP children, it is due to chororetinal degeneration. Will it be due to post laser, or we see myopia in non-laser children also?
Yeah, so ROP basically leads to some kind of developmental changes in these eyes of preterm babies. So these babies do develop myopia to some extent. Obviously, it's very well documented that if you have small zones ROP where you do extensive laser, it can lead to high myopia. So we get babies with -15 myopia, -20 myopia. It can all happen. So injection helps in these cases where it helps to avoid this. However, if you do injection with laser, again you can get high extent of myopia. So this risk is there, but these risks do outweigh the benefit which is there, that you get disease regression, and at least the disease regresses and the child can see.
Can I just add a question and a point here, Dr. Parijat? What I have noticed is there is no direct correlation between amount of laser and myopia at times. I mean,
Exactly.
the myopia may go much beyond. Sometimes
Yes.
you feel the laser is quite less that you have done and the myopia is quite high.
Exactly. You can't exactly say which case is going to, say it was only this is going to develop -15. It's not like that. It depends. It varies. Yeah, of course.
Right, sir. There's another question by Dr. Bhavna, and that is that in zone 1, does early anti-VEGF have a better prognosis?
Yeah, so again, if you have zone 1, you have plus disease, you have very clear-cut APROP happening, vascular loops, then what are you waiting for? See, so as I like to put it to my postgraduate students, the disease should be under your control. You are the surgeon, the disease should be under your control. If you let the disease worsen, hemorrhage has started, pneumothorax has started, a lot of other problem has started, then you go in and the child is in your screening program for 3 weeks, 4 weeks, it's a total injustice to the child. We should laser inject surgery at a situation where the disease is under your control and the outcomes are predictable. So if you go in early for any of these things, the outcomes are predictable. If I do injection today, I know what is going to happen after 1 week, 2 weeks, 4 weeks. However, if you allow the disease to worsen and the child is in your screening program, the parents are going to get very anxious. That I was referred here saying that, the child has this kind of problem and the doctor is just waiting. So what are you waiting for? What are we waiting for? So the idea is to go in early when there's a clear-cut indication for a treatment and not continue to wait and pray that the disease will go away. The disease will not go away if the indication guideline is there. So keep the disease under your control when the outcomes are predictable. Don't let the disease go out of control when the outcomes are unpredictable, and even after injecting or doing laser, now you don't know. You're explaining to the parent, I have done it, but I really don't know how it's going to happen. So we should not get into that stage if the child has come in time. Keep the disease under your control, have the predictability. You will be more comfortable, the parents will be more comfortable because you know now what the outcome will be.
Right, sir. Dr. Ritesh, would you like to add something to that, sir?
No, I absolutely agree with what Dr. Parijat is saying here. Once you are taking a child under your follow-up, then there is no point in delaying a zone 1 eye. We know the device, and it progresses really rapidly. At times, if you are just thinking of waiting and in front of your eye, the stage would just go into a severe worse disease. So in zone 1, it's better to err on the side of an early treatment, I would say.
Right, sir. So there's a question by Dr. Soni that straightening of temporal vascular arcades in eyes, what differential diagnosis we should suspect besides ROP?
Yeah, so ROP is a very clear-cut situation. Fortunately, we have a very good history. The parents will tell you that my child is preterm. So if a child, so the parent tells you the child is preterm, it is ROP. Most likely is ROP. And again, just like to reemphasize the fact that if you have a dragged macula, the arcades are stretched, that means we missed something. If you have a dragged macula, the child is going to have suboptimal vision. The child is going to have a possibility of squint. So in a situation where we could have lasered this eye and treated it at an early stage, all these things would not have happened. If you get a drag, that means something happened in the periphery which caused traction, which pulled these arcades toward itself. So we should have avoided it in the first place. The second thing which you asked was for the differential diagnosis. So
Right,
if it's a preterm case, this is the main diagnosis. You have to just see it's happening. It should have been treated earlier. The drag should not have happened in the place because it becomes like a sequel now of 4AB ROP. If your child which is full term, then obviously there are a lot of differential diagnosis which could be there. FEVR is the most common one, obviously. There could be concentra pigmenti, which is there. There's a whole range of diseases which are there. Although fever is the most common.
The confusion happens more when a person presents much later in life with a kind of a dragged macula where you're not sure whether it was a regressed ROP and you don't get a convincing history on an FEVR. As Dr. Parijat is saying, in ROP, the history puts it in front of you.
Yeah.
So in that age group, it doesn't trouble you that much.
Yeah, but the mechanism and the treatment stays same. Right. Whether it's FEVR at a later stage or ROP at a later stage, basically the problem is you had an avascular retina, which maybe someone didn't pick up, which led to some traction, which led to that drag, and now you have to just look for it with wide angle angiography, whether it has some new vascularization, is it bleeding, and just laser that area, and that's what needs to be done.
Right, sir. So this is a very common confusion amongst all the postgraduations and postgraduates, and I think let's just mention that question. That please differentiate between plus ROP and advanced ROP, if it's possible.
Plus ROP and advanced ROP.
Right, sir.
So that's no. There's nothing like plus ROP. I'm not aware.
Plus disease, sir.
So plus disease is basically a vascular manifestation, which is basically dilation and tortuosity of vessels. So as I said, it's just a continuum of disease. It goes from normal to pre-plus to plus. So it is a very good indicator of the disease activity. If you are having plus, the moment you look behind and you see plus, that means something is happening somewhere in this eye. You need to now find what is happening. An advanced ROP possibly will mean something like stage 4 or stage 5 ROP. That's just a loose term for that. Someone could call a threshold ROP also as an advanced ROP. So it's a loose terminology. It depends how you want to use it. So we should not exactly use advanced ROP. We should stick to standard classifications, stage 3, 4, 5, which helps in communication between experts what exactly the thing is. Advanced ROP is a loose term. I don't think it should be just used as.
So I think the person who asked the question meant to ask about plus disease versus aggressive ROP. So if that frames the question.
Is a definite constellation of signs which is there. Plus disease is one component of APROP. So plus disease can happen in threshold ROP, it can happen in pre-threshold ROP, it can happen in classic ROP, it can happen every ROP the plus disease can happen. But AROP is a specific constellation of signs where you have vascular loops happening, you have posterior zone, you don't have the classical line ridge coming in, it's a deceptive featureless junction, you have flat neovascularization. In addition to all this, you have plus disease, which makes you realize that the problem is more severe than it actually looks on a fundus photo. And so it's just a part of AROP, is just a sign which helps in the diagnosis of AROP.
Right. So there's a question that how often do you come across Coats disease and ROP together?
So in Coats disease, again, you can have peripheral avascular retina, you can have that. So we don't get it very frequently. So just recently, maybe last month, we had a child who came with vascular loops. He had 2 telangiectasias, and we lasered the child because he was zone 3 avascular. We lasered it, had a lot of tortuosity. But eventually it went on to show a picture of Coats only. The telangiectasias increased, the So it got converted into actually a Coats disease, and because he came into a preterm screening program, he was diagnosed with an avascular retina, and he was continued like an ROP. But eventually, it was a Coats. We don't get it very frequently because a preterm child coming with Coats, which you pick up very early. A small 2-3 telangiectasias lying there, you need a very high index suspicion that this is not some neovascularization which is happening, but actually Coats. But it's very important again to pick up Coats early, because if you can pick up Coats early, you can maybe treat them early before you let them go, and they come back with the exudates at macula and something which will be more difficult to manage.
Right, sir. So another question is by Piyushi, and she means to ask that the myopia which is induced in ROP, it is due to the stretch of the retina or due to the lenticular changes?
So some multiple causes have been attributed to it. If you go in literature, people have proposed different kinds of theories. There's a mismatch of how much the eye length is growing, mismatch of how much the lens thickness is growing, mismatch with the AC, mismatch with the corneal curvature. So a lot of these factors are contributing. There are a lot of studies which have measured the axial length, the lens thickness, the AC depth, and tried to postulate different theories around it. So I think the important thing which we need to understand is that these babies can have myopia. The important thing to understand is that after we have lasered, injected, and done whatever treatment, or maybe they have spontaneously regressed itself, we should get the refraction done at around 50-60 weeks. We should get it done, because these babies might be having myopia, which might be mild or might be significant. And if you let them go, they can come with long-term amblyopia, come with long-term strabismus and things like that, which can very easily be avoided if we have a high index suspicion that these children will have myopia. So basically in our program, all the babies which pass through the ROP clinic, we get their refraction done as a routine at around 50-60 weeks under atropine, so that if it's not there, well and good, but if it's there, then at least we are able to give these children glasses and help them out, and they don't go amblyopic.
Right, so so the last question is by Soni Devin. She's meaning to ask that how often do we do FFA in the ROP eyes?
Yeah, so FFA is I showed basically to show you that how it looks like. It's a very good tool for training and education and things like that. We don't use FFA much because one, you need a red cam, and that also you need a red cam 3 to do this. So you can't do it with the shuttle, you can't do it with a lot of other instruments. So it's an expensive equipment, costs, so many people don't have it. So obviously there's no way to do it. But even if you want to do it, we basically do it in cases where there is a diagnostic dilemma kind of thing is happening, where we are having kind of a recurrence, and it's not very clear that you've lasered the child, you have given an injection, everything seems to be okay, but the disease keeps on recurring. Now possibly is what we have found in these cases, that although the retina appears to be there could be avascular areas, because the vascularization which has happened, the capillary network which is formed is not so healthy, and what has formed is not absolutely normal, and this abnormal kind of retina which is there is causing that ischemic stimulus. So mostly when we laser that, it tends to finally stop reactivating every few weeks. Or maybe you have some case where sometimes you get cases where it's gone till zone 3 very nicely, regressing, but there are some posterior patches of avascular retina, and again you're not sure what is happening there, so you need to laser behind. So multiple scenarios happen where you need to do it, and obviously it's a very good useful tool for residents and trainees where they don't see it, but if you show them that this is how it's happening. And obviously disease like Coats or disease like where reactivation is happening and you're not sure why it's happening. So mostly everything can be picked up clinically, and if you can pick it up clinically, that is the best way. And obviously most people don't have a red cam and with the angiography module, so it's not really an essential requirement to learn and have, and you can examine these patients clinically. You can get away with it.
Right, so Ritesh, so would you like to add some comments to that?
Just one last question for Dr. Parijat. Parijat, how do you follow up kids who are being treated, who you have treated with an anti-VEGF injection, whatever disease stage? What is your normal follow-up for anti-VEGF treated kids? And number 2, how often do you need to repeat anti-VEGF injections in these kids?
Right. So if you give an anti-VEGF in zone 1, we are well aware the disease regresses immediately, and a very good outcome is usually obtained. Now it becomes stable, and we are waiting for it to grow. So good strategy is not to immediately go ahead and do laser The idea is we want to let it grow. So we let it grow. We follow up the child every, let's say, 2 weekly. Now we know that around 6 to 8 weeks, the disease is going to come back. 6 to 8 weeks, 9 weeks, critical zone when it's going to come back. So then if you see a faint line has come back, or maybe some early pre-plus has started to come back, maybe you can continue to watch every weekly. So usually around this time, if a significant PAR is there, the disease will come back, and you don't want to again miss the reactivation and let it go to stage 3, where again you can't control it. So we regularly maintain follow-up 2 weekly, and we find it's coming back. At the first sign it's coming back, we go ahead and do the lesion. The second option you said was
Repeat anti-VEGF.
repeat anti-VEGF. Okay, so repeat anti-VEGF we usually don't give, because even if you have a case of zone 1, it usually grows into zone 2. Many times it does not grow into zone 3. Small areas left, we laser it and finish it off. Second injection is not required. Second injection we find is needed in some babies where they don't come back for follow-up or something, and they come back with again a very aggressive kind of picture of reactivation. So again, as we know that the laser takes time, laser will take 2-3 weeks for the full response to come and get it down. Sometimes if it comes back aggressively in zone 1 or zone 2 posterior, and we know laser is not going to work in this, and maybe the child has lost follow-up, come a little late, so we again re-inject in these eyes, again control the disease, again let it grow a little, and then we do again laser in the next setting. So we find it works very well in those scenarios. Sometimes some people I've seen they inject, if the zone is small, they want to inject again and let it grow further, like what the rainbow study tried to do. So again, that also works in some places. They like to re-inject at 4 weeks, 6 weeks before the reactivation has happened. It continues to grow a little more, and then possibly they want to do it. There were some children where we had to re-inject multiple times because they were injected, lasered, and still the disease kept on coming back. And they did need multiple injections because the child is already lasered, already injected, and the disease comes back again and again. Maybe the retina which formed was again not healthy, which came back. So they did need 2-3 injections for the disease to control. Sometimes we switch the injections. If we are on Lucentis 2 times, it keeps on coming back, we maybe give Avastin the 3rd time if it keeps on coming back, and that usually fixes it. Maybe you can give Avastin the 2nd time if it keeps on recurring very quickly. So usually we use Avastin as a 3rd injection. If 2 times Lucentis it keeps on coming back despite laser, then we need to switch.
Right, sir. Thank you, Parijat, sir, for the wonderful session. And everybody should know that retinopathy of prematurity is a long question or short question. Staging can come separately, so please make sure that you make your notes. And you should see the lecture again and again to grasp, because so many things they get missed, and they're very important sections to be written in as an answer. And thank you, Ritesh sir, for sparing out your time for the discussion. And next we will have on the February 16th, the class will be on pediatric retinal disorders by Professor Moderators.
So thank you so much. Thank you, Dr. Hanover. Thank you, Dr. Ritesh. And thank you for this honor and opportunity to be a part of your excellent iFocus course. And thank you, Rolika. Thank you, Christy. It's really an honor to be here. Thank you so much for this opportunity.
Thank you, Dr. Parijat. Thanks a lot.